Care Delivery Model Redesign and Making the Case for a Tribrid Approach to Caring Differently is our episode topic. My guest is Dr. Katie Boston-Leary, Senior Vice President of Equity and Engagement at the American Nurses Association. Dr. Leary was a contributor to the nurse staffing think tank, Priority Topics and Recommendations. She is also a 2023 International Council of Nurses Global Nurse Leadership Institute Scholar and has also testified on various Capitol Hill panels and roundtables regarding nurse staffing and regulatory burden on hospitals and nurses. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Katie, thank you so much for joining us today.
Happy to be here.
Can you tell us a little bit about yourself and, frankly, how you ended up at the American Nurses Association working there full time?
I finished my doctorate and I was looking for a change because something was stirred in me where I wanted to do something broader for social impact, social change, particularly in the field of nursing and healthcare. I had been a chief nursing officer for a few years, and ANA and we found each other around the same time. They were looking for a director of nursing programs to oversee nursing practice and work environment issues. I was looking for, as I mentioned, how I can impact the profession just more broadly. And it became a fit. A friend who works at ANA sent me the job posting, and the rest is history. So it's 4 years later, and I love what I do.
Excellent. And so we've had a lot of previous episodes. We've been talking about workforce and what workforce looks like and engagement and discussing concepts of DEI in the workplace and then also workforce models in a post-pandemic environment. But I understand that you've spent a lot of time recently looking at the workforce structure for nursing. And so can you tell me a little bit about that project?
There's so many parts of this work that I could share, but starting with in 22 at ANA, we convened a think tank to work on how we can do some immediate work to address the nurse staffing crisis. We felt that things were really at a point where it was at crisis levels, and we saw all that was happening during the pandemic, and we just felt that we needed to do something. So we assembled a group of leaders, not only nurses, but leaders in health and human resources and even a patient advisor. And we went to work, and we felt that group through 6 meetings with good intention and effort and engagement in between meetings. We felt that we can get it done, and we got it done and put together some recommendations in 3 to 4 months. And those recommendations really entail what leaders can do at the institution level to address the nurse staffing crisis. At the top of the list was building a healthy work environment. Second was diversity, equity, and inclusion. Third, work schedule flexibility. Fourth, stress injury continuum, addressing all the pieces with compassion fatigue and moral distress and all the challenges that we face as far as the psychological impact with what we're facing. And then fifth, innovate care delivery models with urgency. And 6, total compensation, which includes salary and benefit.
You listed 6 items. Are those in priority or are those just 6 items that are the key areas?
That's a great question. The first 2, yes. And actually, I'll say the first 3. But I do believe that stress injury could also be at the top because you want our nurses to be in a healthy mindset when they're working, and we have to address that. And they all feed into each other. But we did feel that the healthy work environment was at the top of the list intentionally because everything has to be built on top of that. Anything else, I think, comes after that. But healthy work environment, we felt that is anything built on top of an unhealthy work environment is a house of cards. So that's why we put that at the top of the list.
Okay, thank you.
So then after that, we convened a task force. We pulled over folks from the think tank work, but we also made sure we included some new folks that could really give us some insights with policy impact that could happen to put this issue to bed once and for all. Because as Nick, we've been in this place for a while with having a nurse staffing shortage or what have you for decades. This group focused on what can be done at the policy level, at an agency level, for there to be long stemming impact. So with that group, we decided we pulled back healthy work environments being number one. Second, we focused on the fact that we need to address the value of nursing. Third, brought back innovating care delivery models to make sure that we innovate from a place of addressing workload and also leveraging technology. And then fourth, maximizing efficiency with regulatory innovation. And the fifth was really looking at how we can address nurse staffing standards from a policy approach. So those were the 5 imperatives, we call them, that we established with the task force.
Thank you so much, Katie. The topic of our episode today is care delivery model redesign, making the case for a tribrid approach to caring differently. So, what exactly are we talking about when we're looking at this tribrid approach? What does that mean?
We really felt that it would not be our place to say this model is a model you should take over whatever else, and we know that there are a number of different models out there and there's been a number of trials. But we did feel that there was a place for us to establish the tenets around establishing a strong model of care delivery that everyone could live with, that could actually spill over into any model that's developed. And the key piece of this model and this approach is understand that technology is here. It has to be built into whatever we build for us to be able to have a successful model that can be sustained for what we're trying to achieve. So the key pieces of it, the 3 parts of it, and we actually defined it. Let me start with the definition, the operating definition of care delivery model. We developed this definition and we said that it's models that combine high tech and high touch, which for high quality care, with an inclusive and integrated approach for patient and nurse satisfaction, reduction of practice pain points, and improved outcomes. So when you listen to that, you see where we're going with addressing the fact that we have to have a tribrid approach. And the tribrid approach is really building on, we all know about hybrid environments that we work in and hybrid automobiles. And we thought about that and said, we can think about a tribrid approach, a tribrid model to care delivery. So one, of course, recognizing that nurses will always be at the bedside. We'll never have empty hospitals with no nurses in them or places of care delivery. And it may come, but for now, we can't see it. But the second part of this tribrid model is to have a nurse remotely caring for that patient as an extra layer of care delivery and making sure that patients are receiving the care that they need, that surveillance piece, that virtual nursing aspect. That's what we were talking about there. And then the third part is really leveraging technology to reduce the burden of care for nurses, where it's about how we should have technology that uploads vital signs. We know we're in a time where nurses still write their vital signs on pieces of paper or on their pant legs and on their scrubs and put in the computer later. So how can we use technology to make sure that's happening in the background, where a lot of this rework is happening in nursing care delivery? We know that even with doing assessment, nurses have to document that or write that in some cases, in most cases, and then document it in the computer. How can we set up our systems so that it's happening automatically while the assessment's going on is being uploaded in the system in our EHRs? So those are the 3 arms of the tribrid model that we were discussing and that we developed in this approach to redesigning care.
Is this tribrid approach really intended for in the hospital setting, in the ambulatory setting, anywhere care is delivered? Is it across the board or more specific?
So when we did this work, we were focusing mostly on the acute care setting, but we also believe that there's scalability and replicability that could happen in other settings as well. And but the other thing to recognize, and we've all seen it as healthcare consumers, we know that particularly in the primary care space, this is already happening. We do see with the example that I gave with the documentation that happens in a synchronized way while the physicians in the room or the providers in the room that's caring for you, that information is being uploaded in some cases. And with AI, we're also seeing and hearing that it happens, it's all uploaded even before the provider leaves the room. So we'll like to see some of what the improvements that we're seeing in the ambulatory setting to happen in the acute care setting, where most of our nurses are caring for patients, because we still have the numbers mostly there. Almost 60% of nurses are practicing in hospitals. And we believe that's also where we're having the exodus of talent, leaving that setting because of how hard it is. So that's why we really felt that we had to focus there, at least first. But there is opportunity for that to go in other settings, but we also believe that other settings are actually doing better in that place, in that space compared to acute care setting.
You mentioned AI briefly to what, and that clearly that works itself in to the technology component. Where do you see AI adding value in the practice of nursing, and what comes to mind when you're talking about AI as it relates to nursing?
We do know that AI it's happening more insidiously where we don't see how it's impacting what we do in our private lives compared to even our professional lives. But we do know that it's having an impact on outcomes. We do know that it's also impacting more on the provider side than on with diagnoses and things like that compared to what we're seeing in nursing. And we also know that there is a bit of a negative stigma or a stigma that's happening with AI in nursing that we really need to address. AI can be built in a way where it doesn't have the biases that we're concerned about right now, where it can benefit nurses. And I think because of the way we document with flow sheets and everything, it's not having the impact that it should, but I think it's coming. One of the things that I know I heard recently about how it's being utilized in an institution is there's an organization that I heard about that has buttons that they put on patients where they're tracking patients' physiological monitoring throughout their stay. And it sends alerts to nurses, and the system is built where it sends alerts and information to nurses based on whether there are changes in their vital signs. And one organization that reported on this said that one thing they didn't account for was sometimes when we're sleeping, particularly when we're in REM sleep, our blood pressure changes, and that was setting up unintentionally some alarms that were going off that were creating unnecessary alarms that made it challenging for nurses to deal with. But we do believe that there's a lot of opportunity there, and nurses need to be at the table to build these systems so AI can work for them.
There's a lot of different organizations out there right now doing different staffing analyses.
These recommendations that I shared with you, particularly the think tank recommendations, were developed in partnership with AONL, the IHI, which is the Institute for Healthcare Improvement, HFMA, the Financial Management Association, and AACN, the American Association of Critical Care Nurses. So we called ourselves the Partners for Nurse Staffing, and we worked together on putting together those recommendations from the think tank work. The task force work was developed with the American between ANA and the American Association of Critical Care Nurses. And that's how we've made those connections. Now, the American Organization of Nursing Leadership also has a care delivery model committee that I represent ANA on that committee. And we're working together on a number of these challenges and redesign that needs to happen with care delivery models. And then the last thing I'll mention is there was a partnership between Johnson and Johnson and IHI to help nurse leaders develop care delivery model redesign with their support And that work has been done. And ANA and AONL had representation there. So you see how it's all matrixed and we're all working together to solve the same issue. And that's really because it requires us all and all these organizations to work together and not do silo work. So that's what I'm happy to share to answer your question.
Yeah, you took the words out of my mouth. I was getting ready to say, it sounds like we're not operating in silos, which is a wonderful place to be. Yeah, what I hear you saying though, is you're talking about this tribrid model, and let me say it back to make sure I understand it correctly, is really, if I'm a chief nurse right now, I need to be looking at kind of three things if I want to consider this model, or I should be considering this model. One is, how am I delivering care at the bedside? That's the first part. Two is,
Yep.
to what component can I deliver care remotely? And three, how do I use technology to essentially bridge the gap? Is that a quick summary of an understanding of that?
It is perfect, Nick. The only thing that I'll add is the third piece is about reducing the cognitive and physical workload for nurses. That's what the third arm is mostly about. So, and you're exactly right. If we look at those three components with redesign, we will get there and address a lot of the things that have been plaguing how nurses should be able to really move the ball and care differently. It will really help with that thinking around that. I remember I was talking with the chief nurse the other day, and she was talking about her delivery model redesign. And she was sharing a lot of things that she was working on, was looking at how to, because most of the discussion has been about grouping different groups, people at the bedside. What roles which should we add in or remove, or how we cluster people? And I shared with her, I said, so tell me about how technology is playing into this. And she said, what do you mean? And she said, technology is everywhere. I said, but it needs to be part of your design work. And and the light bulb went off. She said, I never even thought about that. So that's what we're trying to impress upon our leaders, is that technology piece is a part of that redesign. It has to be factored in to whatever we build. And not assume that because it's in the background and we have EHRs and we have a number of the other technology, it should not be brought in. It's a part of that redesign work.
And I appreciate you clarifying my understanding of the third component, because what I heard you just saying is a lot of time we've got technology because we want to make sure that we're billing the patient appropriately, or we want to make sure that there's revenue or there's some value add for the patient. But here we're really talking about using technology as an adjunct to reduce the burden that exists on nursing practice right now. And that needs to be
Exactly.
the value add. So thank
Exactly.
you so much for clarifying that. While I have you, though, you did bring up an interesting point, which is so much of the conversation right now among chief nurses is, what is the right skill mix? What is the right team in this new environment? Do we use LPNs or LVNs, depending upon the state that you're in that care delivery model? And what is the right mix from an educational perspective of, do I bring in 2-year program graduates with associate's degrees and move them on a BSN completion program? Or do I look at exclusively hiring BSN prepared nurses? While I have you here, I figured I'd ask you the question of, what are your thoughts around the various different academic preparations as well as licensures that exist in forming the appropriate mix, both in the acute care setting, but also maybe out in the ambulatory setting as care is reimagined?
For years, particularly during my time, we've looked at skill mix from a standpoint of reducing costs. And even though we have to be mindful of margins because of the fact that healthcare is, after all, a business, that's not the place to stay. The pandemic forced a lot of leaders to relook at old policies about not having LPNs included in their care delivery models, particularly in acute care settings. And they've opened the door. And my position on that is keep that door open. We've, I think, created some harm over the years with othering LPNs and in some cases also ADNs, which I was when I first started into the profession. We need to make sure that it's known and accepted by all that this work requires all of us. So I'm all for having LPNs at the table and with redesigning these models. I recall when I was a chief nursing officer before the pandemic and I worked in a rural hospital, my days of posting a position to actually hiring a competent nurse could stretch, in some cases, to 18 months, mostly because I was sandwiched between two major hospitals that offered a lot more to nurses in terms of their portfolio of services. Of course, they were a draw compared to my small 100-bed community hospital. All I had in my backyard was an LPN program at a community college to partner with to bring their new grads in addition to some of their ADNs. I work with them from the ADN perspective to bring those ADNs in, but I also was curious about the LPN program. And I worked with my leader in my med surg unit as a start to pull LPNs back into the acute care setting. And this was before the pandemic. And we found some successes. There was some resistance for sure. But what we did was we marched through this in lockstep with nurses. We co-created the plan. We did a survey, like what are the things, where are your pain points and what you do, and what do you think should be delegated? We then use that information to establish a job description for LPNs, check with the Board of Nursing, work with the college, work with the folks that graduated at the top of the program, brought them in, establish relationships. And then when we brought them in, we made sure that they were seen as nurses and not as anything other than that, because there's some institutions that are even creating uniforms for LPNs different from their RN. So you have to factor in all those pieces. And yes, we have to look at how we set up our teams for us to deliver care in a more effective way. But we have to put down some of the old thinking that we had about this to say that if we quote unquote water down the skill mix, patients will die. And that's not what we're saying at all. I think with the proper co-creation of and building of these models with people that understand and have a full stake in making sure this is right and working out ways and approaches to measure success over time, it can be done right. I know you always need to have an RN at the bedside for sure. But on top of that, we have to think about the other players and the other members of the team that could really make sure that we can set up these care delivery models that will be effective, not only for our patients to be cared for the right way, but also for nurses and the people that care for patients to be cared for the right way. Because as leaders, our jobs are not to take care of patients. We take care of the people that do. So that's why we have to really think about this differently. And I'm all for looking at and all the work that's happening right now with revisiting a lot of the things that we thought were that are not necessarily the case, because our eyes are a lot more open and our minds are open compared to where we were a few years ago.
So many of our guests on this podcast series that I've been talking to, and you just mentioned that you were an associate degree nurse. There are countless ones that I've talked to that have started their career in that path and not
Yeah.
entered practice at the BSN level. Dr. Anna Valdez, editor in chief with the Journal of Emergency Nursing, and Dr. Jerry Mansfield at UTMB, just to name a few. Your title in your newly promoted role is Senior Vice President of Equity and Engagement. And so I'm just wondering your thoughts as we think about this workforce also from an equity perspective of the varying different opportunities to enter practice.
We're doing some work in this space at ANA, and this connects to DEIBA, which is part of the work that I've been working on, but I'm leaning more into with this new role. And we know that somewhat intentionally and unintentionally, this has impacted the diversity of nursing. And we know that for a lot of us, and I know Dr. Anna Valdez pretty well, we share a similar story. I would not have been where I am today if it weren't for the fact that I was able to enter nursing through an associate's degree program, because I did not have the resources and ability financially to get into a 4-year program. So for a number of us, and I was on a panel yesterday after filming the Robert Wood Johnson shift film, Everybody's Work. Almost so many nurses in the room that did the Me Too on the fact that they started their careers as associate degree nurses. And one of the stories in that film was about an LPN who wanted to get off of food stamps and wanted to provide for her children. And that's the program that she chose. And after she got into that, of course, there's so many nurses that are primary breadwinners in their families. They're not able to move forward and matriculate because it's not just about providing maybe financially the ability to cover their tuition costs and maybe books. But we all know when you're in a nursing program, you can't work full time. So what's happening on the support side? How are your bills being covered, right? In terms of keeping a roof over your head and keeping your lights on and being able to get food, because you're going to have to find some type of support in these programs, especially once you get into the nursing program, to cover some of those expenses. And some of these folks have single mothers, single fathers, and things like that. So we have to be mindful of those aspects. And that's how we think of this from a equity mindset and be socially responsible and how we rethink how we've set up some of the barriers for people to matriculate to become RNs, and also provide avenues for people to enter into RN programs. Because I do think that has been what has hurt us in terms of impacting the profession from a registered nurse number standpoint to have more diverse nurses in that space.
I'm curious. We look back at the Tribrid model. We've got the bedside nursing. The second one, though, is remote monitoring. And I'm just wondering, are there any standards out there with respect to remote monitoring as a nurse or virtual nursing?
No, as far as we're concerned, there aren't any. And I'm happy to say at ANA, we've assembled a committee, a group of panelists of SMEs in a space to work on exactly that. Right now, we have a working definition of virtual nursing that we hope to publish along with the standards and principles. And we're now actually at the place of revising these. We had some old principles called connected health that was a build for the initial principles that were for telehealth. And we're revising those to get to principles and standards for virtual nursing. And we were really excited about that work. And we really do believe that it will help a lot of the growth we've seen in that space so that it could be done right. We're factoring all types of considerations in terms of license portability, financial, legal, practice standards, because we want to make sure it's seen as an augmentation versus a replacement. So we're excited about what we're going to do here. And we hope to put it out to a small group for public comment for us to get it published relatively quickly, because this is something that's been asked for quite some time. And we look forward to pushing it out to the masses to review it and utilize it.
Any closing thoughts as we wrap up this episode?
As nurse leaders, we have a heavy charge. This is something that has been a long time coming, this change that's here, but we're here now, and I think we should embrace it fully. And I really do believe that a lot of great work is being done. And I do also believe that we need to make sure that we understand that the future of healthcare delivery is here. The future is now. And we need to assume and own these spaces and lean into this work heavily, seek the support that we need to get so it can be done right. I talk about how we just mentioned virtual nursing, but it's really about the fact that virtual care is a disruption that we need right now. A lot of what we used to have with the number of nurses that we used to have at the bedside, that's going to change relatively soon, and we need to be prepared for that. I congratulate all the nurses that are doing great work in this space, and I look forward to seeing how we can support all of you in this space to make it better, safer, stronger, and sustainable over time.
Care delivery model redesign and making the case for a Tribrid approach to caring differently has been our episode topic. The nurse staffing think tank priority topics and recommendations that Dr. Leary mentioned is readily available online. You can Google that to obtain that report. Dr. Katie Boston-Leary, thank you so much for your time today.
Thank you, Nick. Pleasure to be with you. Thank you for having me.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.